Mucormycosis. What is mucormycosis? It is a serious but a rare fungal infection. The older name is zygomycosis, and the causative organism are a group of moles which belong to the class Zygomycetes or Mucormycetes, and the most common organism in it is Rhizopus oryzae. The location of the fungi is in the environment as well as in the soil, most commonly in the decayed organic matter, and the route of transmission is either by inhalation of aerosols or percutaneously. Coming to the pathology of mucormycosis, the fungal spores enter the body by either inhalation or skin inoculation. Inside the body, the neutrophils and macrophages try to phagocytose it, but it is inhibited by various factors like neutropenia, high-dose corticosteroids, iron overload, or acidemia as seen in diabetic ketoacidosis. This leads to proliferation of the fungi and later angioinvasion and dissemination. So why is it that this disease is so dangerous? It's because the angioinvasion leads to cerebral thrombosis, there occurs perineural spread of the disease, there is fast progression of the brain infarcts even before the culture reports. As the rhinocerebral variety is the most common, the proximity to the brain makes it more dangerous, and the disseminated form has 96% mortality. Coming to the types of mucormycosis, the most common one is rhino-oculocerebral mucormycosis, which is seen in 50% of the cases. The next is pulmonary mucormycosis, and it is seen most commonly in patients with leukemia or neutropenia. The cutaneous mucormycosis, which is caused by direct inoculation of the fungal spores into the body. The gastrointestinal mucormycosis, which is seen in premature infants. The bone and joints types of mucormycosis, and the disseminated form of mucormycosis, which is the most dangerous variety. The dissemination most commonly occurs into the brain, and the most common site from which it occurs is the lungs. Coming to the symptoms of rhino-oculocerebral mucormycosis, the most vulnerable or the most important days are the 10th to 50th day post-COVID. Symptoms like pain, facial pain, sinus pain, teeth or gum pain, headache, etc. can occur. Paresthesia, that is decreased sensation over the half of the face. Blackish discoloration of the skin as in the nasolabial groove or ala nasi can occur. Nasal crusting or discharge, that is blackish or blood tinged. And orbital features like decreased vision, proptosis, etc. can occur. Signs like in the nose we have to look for crusting, black middle turbinate, pale insensitive mucosa, eschar or ulcers. In the eye there can be ptosis, chemosis, proptosis, periorbital edema or ophthalmoplegia. In the brain there can be altered sensorium, seizures, hemiplegia or cranial nerve palsies. And inside the oral cavity you can see palatal discoloration, palatal ulcers or eschar, loosening of the tooth or orodental fistulas. Therefore, all these sites or all these parts have to be thoroughly examined. The clinical stages of rhino-oculocerebral mucormycosis are: the first stage is the rhinomaxillary stage, which involves the nose and the paranasal sinuses. The second stage is the rhino-orbital stage, which involves the orbit. And the third stage is the rhino-orbitocerebral stage, which involves intracranial part. So why is it that diabetics have increased risk of mucormycosis? It's due to various factors like beta-hydroxybutyrate, which is a ketone body seen in diabetic ketoacidosis. It leads to dissociation of the iron from its sequestrating proteins, and this causes free iron, which increases the fungal survival and virulence. Next factor is the upregulation of GRP78, which enhances tissue penetration. Hyperglycation of the iron sequestration protein, which again increases the free iron in the body. Reduced phagocytosis due to impaired glutathione pathway, and expression of ketone reductase by the fungi that helps it thrive the acidic environment as seen in diabetic ketoacidosis. So these are the factors which make the diabetic patients more prone. The other risk factors are immunocompromised states like HIV, post-burn or trauma patient, use of high-dose corticosteroids, self or prolonged use of broad-spectrum antibiotics, malnutrition, organ or bone marrow transplantation patients, ROCM therapy, and malignant hematological conditions or neutropenia. Some of the predisposing factors which are of debate are traumatic soil implantation, improper use of humidifiers, excessive steam inhalation which alters the mucosa and makes the patient prone to mucormycosis, depleted adaptive response post COVID-19, use of same mask for prolonged duration, increased zinc usage which is again linked with increase of fungal survival, and inhalation of construction dust or rotting vegetation, use of industrial oxygen or dirty bed linen. Coming to the diagnosis, the gold standard radiological investigation is MRI paranasal sinus with gadolinium contrast, which shows the black turbinate or the black mucosa sign. This is the black turbinate and the black mucosa sign due to mucosal interruption or due to the involvement of mucosa causing its necrosis, as seen in the MRI. Next is diagnostic nasal endoscopy and biopsy, which can be done. Nasal swabs or scrapings for fungal smear, culture or microscopy can be done, and HRCT chest for pulmonary mucormycosis. This is a carriage mount showing the acetate fungal hyphae. This is the Gomori methenamine silver staining of the fungus. This is the lactophenol cotton blue or the LCB staining, and this is the ribbon-like hyphae in modified Giemsa stain of frozen section. In the culture on SDA medium, we can see salt and pepper appearance as seen in this picture, and histopathology shows broad acetate hyaline hyphae that is ribbon-like with wide-angle branching. This is the dead serpent sign due to thrombosis of the internal maxillary artery, sphenopalatine or greater palatine artery depending on the site of the endoscopy in mucormycosis. So due to this thrombosis of the vessels, it appears like a dead serpent. So this is an important sign seen endoscopically. Next is HRCT's chest showing halo as well as reverse halo sign. Coming to the treatment. The success of the treatment depends on a multidisciplinary team approach. Early diagnosis is of utmost importance. Surgical debridement should be done. Prolonged antifungal therapy, strict glycemic control, and reversal of underlying cause if any. Why is early intervention necessary? It's because of its high mortality rate, poor prognosis, rapid progression, which leads to carotid artery occlusion or cavernous sinus thrombosis, and permanent residual effects, which is seen in 70% of the time. Coming to surgical debridement. All the necrotic tissue as well as visible fungal colonies has to be removed during surgical debridement. It helps in better penetration of the antifungal drugs as well as lowers the mortality significantly. So in the early stages, that is stage 1 and all, you can do endoscopic sinus surgery. But as the stage increases, as the disease progresses involving the maxillectomy, that is partial or total, or even if the zygoma is involved, the zygoma debridement, etc. needs to be done according to the invasion of the disease. When the eyes or the orbit is involved, we can try transcutaneous retrobulbar amphotericin B injections, and in extensive cases, we may need orbital accentration. Coming to the antifungal therapy, the drug of choice is amphotericin B, and the most preferred preparation of it is the liposomal variety. The dose is 3 to 5 mg per kilogram per day, which can be increased to 10 mg per kg if the brain has been involved. So as I said, this is the most preferred drug as it has the minimal side effects. But the main problem with it is costly, costing around 6,500 rupees per 50 mg vial. The next variety of preparation is the deoxycholated variety, which has a dose of 1 mg per kilogram per day. This is the most toxic one, causing nephrotoxicity, electrolyte imbalance, infusion-related toxicity, etc. But it is comparatively cheaper. Another preparation is the lipid complex preparation, which is better than the deoxycholated variety, but still it is having more toxicity than the liposomal amphotericin B. The dose is 5 to 7 mg per kilogram per day. This is a chart showing the administration of liposomal amphotericin B. As I said, the dose is 3 to 5 mg per kilogram per day. We have to properly hydrate the patient, that is 500 ml of NS should be given 1 hour before infusion as well as post infusion. For the reconstitution of the drug, 50 mg vial, into a 50 mg vial you have to add 12 ml of sterile water, which makes it 4 mg per ml solution, And we have to remember, never use NS with it because it may precipitate the drug. The diluted amount, we have to withdraw it into a syringe, attach to a disposable filter which comes along with it, inject the volume into the same amount of 5% dextrose. That is, if you take 250 mg of liposomal amphotericin B, you have to dilute into 250 ml of dextrose. And then give it through an existing IV line after flushing with 5% dextrose injection prior, or otherwise you can give through a separate line. The duration is of approximately 2 hours, and you can decrease the duration of infusion to 1 hour if the patient is well tolerating, or otherwise if patient is showing any kind of discomfort, you have to increase the duration to up to 4 hours. The monitoring parameters are, you have to look for acute infusion reaction which occurs usually in the 1 to 3 hours after infusion, like fever, chills, rigor, chest pain, dyspnea, flushing, urticaria, nausea or vomiting. And to prevent that, usually we pre-medicate the patient with Avil or paracetamol, and if any of these reactions occurs, you have to stop the medication and give the patient hydrochlorodexa as required. Other monitoring parameters are, we have to do the RFT and serum electrolyte, LFT as well as CBC almost every alternate day. Especially the RFT and the serum electrolytes has to be repeated every alternate day at least. And do not use any other nephrotoxic drug concomitantly along with this amphotericin B. Coming to the other antifungals which are used for step-down therapy, the first one is posaconazole, which is given at a dose of 300 mg twice a day on day 1, followed by 300 mg once a day. And we have to remember the single 100 mg tab costs around 500 rupees. The isavuconazole is the next drug available. The dose is 200 mg 3 times a day on day 1, followed by 200 mg once a day, and the single 100 mg tab costs around 6,200 rupees. Even after being so costly, both of these drugs are very difficult to get in the market. So all these factors make it more difficult to treat the mucormycosis completely. Clarifying some misconceptions regarding the disease. First of all, we have to understand that mucorales are not black fungi. The black fungi are a group of pigmented fungi which has this black pigment in it, but mucorales have got this name just because of the necrosis and the eschar, which is seen as black in black color. Due to that, the name or the misnomer black fungus is given to it. Mucormycosis is not contagious. Some people still think that it can spread from one person to another, but we have to understand that the fungi is seen everywhere in the soil, in the environment, and only the immunocompromised persons are the ones which get the mucormycosis. There are no antifungal prophylaxis is recommended, as the incidence is not more than 10%. How to prevent? First, proper sugar control should be done. Systemic steroids should only be used in people with hypoxemia. Universal masking is advised. Avoid using the same mask repeatedly. Avoid exposure to construction sites and manures. Use antibiotics or antifungals judiciously, and use clean sterile water for humidifiers during oxygen therapy. And the most important thing is, do not miss any signs or symptoms in the patients coming with the mucormycosis. Thank you.